Okay, good afternoon, everyone. I think a few more people are going to filter in here, but let's get started on time. It's my introduction. My pleasure to introduce Quinn Quinn Danyluk today. Quinn is the managing consultant with Regional Initiatives Workforce Health and Safety with Fraser Health. I'm sorry, I'm so tongue-tied. Quinn obtained his Master of Science from the UBC School of Occupational and Environmental Hygiene and is a certified industrial hygienist. He's worked for Fraser Health for the past 14 years, during which time he's been involved in preparedness and response activities for several outbreaks, including SARS, H1N1, and the Ebola Virus Disease. He was part of the team that developed the original Fraser Health Pandemic Influenza Preparedness Plan and was part of the Public Health Agency of Canada Expert Working Group to revise the prevention and control of influenza during a pandemic component of the Canadian Pandemic Influenza Plan. During the recent Ebola virus disease situation, Quinn has participated as part of the Provincial Ebola Critical Expert Group and along with his team has been immersed in preparedness activities in both Fraser Health and across the province. So very interesting topic for us today. Welcome, Quinn.
Great, thank you. Wow, clapping at the beginning, that's awesome. We'll see if I get clapping at the end. So I'm really, thank you very much for the opportunity to come and speak with you today. I'm really excited to be able to share this. If anyone went to the local section AIHA AGM in the spring, I covered this topic as well. This is a bit of an updated version to what I covered there, but you will see some similarities. In terms of what I want to talk about today is I'll spend a little bit of time, brief time, going over the background of Ebola virus disease. Again, really brief because I'm not an expert on the disease or the pathology of that. But I do want to give some background on what the disease is, how it's spread, some of the symptoms, and what the current state in the world is. And I'd also spend some time talking about the health authorities in BC, a little bit about the structure. But really what I want to focus on is what we did here in BC to deal with Ebola virus disease. Particularly around the PPE and the education training, as well as the logistics involved with the PPE procurement process. I want to talk about the evolution, so you will see where I refer to what was happening prior to Ebola hitting us, what happened and what our response during Ebola, where we're at now, and where we're going. So it was a fluid process and it did evolve as we went throughout. So this is a real book. Unfortunately, there's no hygiene section in it on controls or anything, so I wasn't able to use anything out of this, but it was a book that was circulating last year. One of the questions you may have is, why am I talking about this today? So a year ago, this probably was on everybody's radar. It certainly was in the media, and you may be thinking, well, Ebola's over, it's done with, why have a presentation about it today? Well, certainly from a public interest perspective, the media was very big on this at this time last year, a year ago. This graph here just shows the Google trends on searches for Ebola over the last 2 years. The latest outbreak, the one we're dealing with and it's still occurring, started in December 2013. But certainly it hit the media in the late summer and fall of 2014. And you probably remember a lot of that media coverage. There was a lot going on around there and a lot of concerns, a lot of unnecessary concerns. In terms of whether this actually was a public health issue in North America, outside of about 3 countries in Western Africa, this really was of no impact to the public in most of the world. Certainly for the health authorities, it was an impact, and it still is an impact, and I want to stress that as I go through the presentation today. So even though it's died off in the media, we're probably not hearing a whole lot about it, it's out of most people's minds. It is still a lot of work. There's a ton of work happening on this to prepare and mitigate potential exposures in the healthcare realm. So in terms of the overview, Ebola virus disease is the term being used. It was replaced Ebola hemorrhagic fever. Throughout the presentation, you may hear me refer to it as Ebola virus disease, EVD, or Ebola. I'm referring to the same thing throughout. It was first addressed and first appeared and discovered in 1976, so about 40 years ago. It's spread by direct contact with the infected individual's body fluid. And this can occur through the recipient's nose, mouth, any mucous membranes or damaged skin. In terms of the incubation period, it's quite a range. It can range from 2 days, it can range up to 21 days. In terms of symptoms, there's kind of 2 phases to the symptoms. The first set we refer to as kind of the dry phase. And this is fever, fatigue, muscle pain, headache, sore throat. So nothing really uncommon that's much different than a common cold or the flu. The next phase is what we typically refer to as the wet phase because there was a lot of body fluids involved. So you've got vomiting, diarrhea, you can have internal and external bleeding. And this is the phase in the wet phase that someone's particularly contagious. They're not infectious during the incubation period, so until they actually start to develop symptoms, there's no risk of infection. But it's primarily during the wet phase and to a little extent during the dry phase that we worry about the infectivity of it. The current Ebola outbreak has about a 50% mortality rate, which is extremely large. This graphic is about 2.5 months old. The numbers are fairly consistent, but I wanted to show this because it does summarize a lot of really good information. So if you look at the graphic, and I'll use my mouse here, there's 3 countries that were primarily impacted: Guinea, Sierra Leone, and Liberia. Senegal, Mali, and Nigeria were also impacted, but to a much lesser extent. And Congo also had an Ebola outbreak, but it was a different outbreak. It wasn't related to this one. It is shown on this graphic, though. The larger orange bubble shows the number of people that were infected, and the smaller, darker orange bubble shows the number of people that actually died from the disease. So this really highlights the impact on those 3 countries particularly in terms of the Ebola outbreak. It was very devastating for those, certainly for those 3 countries. The graphic also shows along the bottom and along the top right the number of infections and number of deaths that have occurred from previous Ebola outbreaks. So you can see from 1976 to 2015, up until 2015, there were certainly outbreaks. Numbers were much smaller. This shows the scope and the scale of the outbreak that's happened in the last year, which is orders of magnitude above anything else. This graph highlights, and this is about a week and a half old, but this graph highlights the actual current state right now. So the number of confirmed cases you can see in blue. So the darker the blue, the more confirmed cases in each of these the areas of these 3 countries. And the orange and the yellow dots show the actual number of cases in the last 7 days and last 21 days. So what you can see is right now there's actually not a whole lot of activity happening. So on September 3rd, Liberia was declared by the World Health Organization as having had a stop to the Ebola spread for this outbreak. On November 7th, Sierra Leone was declared to have a stop in Ebola spread for this outbreak. But there is still some slight activity in Guinea. So over the last month, there's been 7 cases. It's all been confined to an individual family. And over the last 2 weeks, there hasn't been any further spread. So it certainly does look like this outbreak is coming under control. This graphic shows very similar. It just shows the length of time since the last case in each of these areas. The lighter colors show that it's been 9+ weeks since there's been any cases identified. And the red shows that it's been less than a week. And again, this is a couple weeks old. In terms of the sum number of cases and deaths, there were over 28,000 total cases. 15,000 of those were lab confirmed cases, and total deaths exceeded 11,000. Again, the primary countries hit were Guinea, Liberia, Sierra Leone. There was, again, some lesser activity in neighboring countries of Mali, Nigeria, and Senegal. But there also were a few cases outside. So Italy, Spain, United Kingdom, and the US also saw cases. And these are from individuals that traveled from the affected areas. So from our perspective in the health authorities, even though there was really a peak in October, November, and it really has declined over time, we still send, and we still have a lot of people that volunteer from our health authorities that actually go over to Liberia, Sierra Leone, and do work, volunteer work. Every week we're getting 6 or 7 people coming back, so we are tracking those people and watching to see if they develop any symptoms. So while from an impact perspective of the number of cases, it certainly dropped off, we still do have a lot of people that we are tracking and making sure aren't developing symptoms, and we need to be prepared if they do. The way that the healthcare, the hospitals particularly organized in BC is primarily through 5 regional health authorities. So Northern Health covers the northern half of the province. Interior Health covers the eastern section, southeastern section. Vancouver Island Health covers Vancouver Island and part of the mainland. Vancouver Coastal Health covers part of the lower mainland and a little bit up the coast. And Fraser Health is the smallest geographically of all the health authorities, as shown in orange on this graph. We actually serve the largest number of clients in the province, and we are the largest health authority by number of staff, physicians, and volunteers as well. So within Fraser Health, we are the most geographically compact. We have 27,000 staff that work. We've got 12 acute care hospitals that stretch between Burnaby and Boston Bar. We serve a population of almost a couple million with a budget of just over $2 billion. So we are a fairly large health authority. One of the nice things about working for it is we can travel from end to end in a couple of hours, whereas some of my colleagues that work in Northern Health, Interior Health, they're days apart some of their facilities. So we are geographically compact, and we do have a lot of hospitals in close proximity. And this just shows some of our hospitals largely spread out along the number 1. Prior to October 21st of last year, when we were trying to manage and mitigate and deal with Ebola across the province, it was really left up to each health authority on how they were going to manage that, what sites they were going to deal with the Ebola patients at, and how they were going to deal with it. On October 21st, the ministry asked that each of the health authorities designate a facility on where they would care for Ebola patients, should one arrive. So there were 5 sites that were designated across the province. Surrey Memorial Hospital was designated for the Lower Mainland. Children's Hospital was designated for children across the province. Kelowna General was designated for the interior. University Hospital, Northern Hospital in Northern BC and Prince George was designated for the north. And Royal Jubilee was designated for Vancouver Island. So on October 21st, that's kind of where we were. On November 21st, that changed as well, and we evolved a little bit. So what was determined at that point is rather than having these designated facilities, we classify facilities by type. So type 1 and type 2 really are dealing with the emergency departments. Type 1 would be assessing, stabilizing, and transferring. So this is basically any emergency department across the province was at minimum a type 1 facility. Anybody may show up unannounced. There's much better controls now. It would be extremely unlikely that anyone would ever show up to an emergency department or any of our hospitals without us knowing because of the tracking that we have and any visitors or anyone arriving in our country. But at the time, any emergency department was classified as a type 1 and had to have that capability. Other emergencies, some in each health authority were designated as a type 2 facility. So they did confirmatory testing, short-term treatment, and packaging and transferring to the provincial designated facility. And then the type 3 facilities were the facilities that would actually receive probable or confirmed cases of Ebola and do the ongoing care. So in terms of the type 2 facilities, again, those are spread out across the province. So for Northern and Interior, same facilities that were designated before, and same for the island with Royal Jubilee and the island. In the Lower Mainland, there's much more, there were more designated facilities for the emerge added as type 2. So we had Richmond Hospital added, Vancouver General Hospital added, St. Paul's Hospital added, Surrey Memorial and Children's Hospital were all part of the designated group as type 2 in the Lower Mainland. But in terms of type 3, and this is what I'm going to really focus on as part of the talk today, there were 2 facilities. Surrey was the designated facility for all probable and confirmed cases of adults across the entire province, as well as children, but Children's Hospital would also receive some children, if any children had Ebola. Now, what would typically happen and what we were expecting to happen is if a child arrived that had Ebola, they would likely be accompanied by a parent who also had it, so we were anticipating that in most of those situations, they actually would have to be cared for out of Surrey Memorial. But it was certainly a much more of a focusing, whereas prior to October 21st, there was kind of a broad range of everybody's kind of have to manage this on their own. It got narrower and narrower in focus. By the time November 21st came around, we had a very targeted focus on where we were going to be doing this treatment. And that's really important, not just for from a training perspective, but from a sustainability perspective. If you're trying to sustain 4 or 5 or 6 or 7 hospitals doing something that is a very rare occurrence, that's much more difficult than having a very targeted focus group where you could sustain it and be much more successful. So that's a bit of a background about the disease and the health authorities and how we're structured. What I'll get into now, it will be the PPE side of things. So again, the evolution of where that started. Prior to the fall and summer of 2014, this was the PPE required in hospitals in BC and across North America if an Ebola patient arrived. And this was based on the CDC requirements, which most of the hospitals follow across North America. It had a set of gloves, single set of gloves, procedure mask, some kind of eye protection, could be goggles, could be a face shield, and a gown. That changed fairly dramatically. And there were a couple of events that really drove that. On September 20th, a patient arrived from Liberia, traveled to the US. 5 days later, he started seeking medical attention. 3 days after that, he was admitted to Dallas, Texas Health Presbyterian Hospital. A couple weeks after that, on October 8th, that patient passed away. 4 days after that, a nurse that was caring for him started developing symptoms. And then a few days after that, another nurse that was caring for him started developing symptoms. Around the same time, a nurse's aide in Madrid also developed symptoms after caring for a patient there. So it became fairly evident that the protocols, the PPE, there was probably an issue with them. Now, the PPE that was being used in Africa over the last couple of decades was much more substantial. If you've seen any pictures in the media, you probably see people in full headgear, coveralls, maybe PAPRs. They were wearing much more substantial PPE than what we were using in the hospitals here. And again, it was something that we'd never actually seen come into our hospitals before. But it definitely highlighted the fact that the PPE needed to be readdressed. So this was kind of our ground zero in terms of hygiene and control and infection control in Fraser Health. We took one of our conference rooms, and within a couple days, it looked like that. And then we had piles of other stuff. It just became an absolute kind of ground zero for us. We started writing on the whiteboards. We started writing on the walls. That's always a bad sign when you start writing on the walls. You're kind of trapped in these rooms trying to escape. But we did spend a really substantial amount of time. As this information was coming to us, we knew there was going to be changes coming from CDC. We knew that there were going to be changes coming from the Public Health Agency of Canada in terms of PPE. We want to get ahead of that curve, though. We want to anticipate what some of those changes were, and we need to develop some of the protocols ourselves in advance of that. So as we started to work through it, we really tried to go through a bit of a method to this. We wanted to address what were types of roles that would interact with an Ebola patient. What were the types of PPE required to protect those individuals? Looking at what type of PPE was currently available on the market, and we have good ideas of this because we use a lot of this PPE in other applications in healthcare, but we want to get a good sense of what was out there. Then we want to procure the PPE. And then we want to develop procedures and processes around how to use it, and then continually assess and evaluate new products and products that were available. Now, in the perfect world, that's what we want to do, but unfortunately, that wasn't the easiest thing. Because as we're trying to determine the roles of the PPE, people are saying, we need to get PPE in right now. The supplies are running out, they're getting really low. Some of the coveralls, some of the companies, DuPont, tripled their production and still couldn't meet demand. So while we were trying to develop, well, who actually needs this PPE and what kind of PPE do they need, we were being asked, well, tell us what we need to order. We were being told to assess the PPE before we actually had it. So while we were trying to do this in a logical manner, there was a lot of questions coming at us from different angles we were trying to address and piece together concurrently at the same time. So again, trying to follow a process, but a lot of needs. And obviously staff were concerned. We wanted to make sure that staff, if a patient did arrive, that staff were actually well protected and trained. So we looked at other protocols and procedures that we had in place to deal with other things, which I'll talk about in a couple minutes. So again, the drivers to change the PPE were coming from some of the information that was out there. The health authorities were operating, trying to work together through the Ministry of Health on standardizing some of these procedures. The Public Health Agency of Canada was in the works of updating procedures. Took quite a while for those to come out. CDC was much more rapid in actually modifying and sending procedures out. One of the nice things for us is we more or less independently arrived at very, very similar recommendations for PPE, both in terms of type and both in terms of the donning doffing processes that CDC came up with. So it did help validate the work that we did in getting prepared for that. But in terms of the PPE usage, and this is an outline of a floor plan of a typical patient room. So we've got the patient room and an adjacent washroom. We've got a hallway that's separated by a door, and we've got an anteroom. So there's a doorway that leads from the hallway into the anteroom into the patient room. Up until this point, most infection control processes, whether you're dealing with TB or you're dealing with other contacts type spread diseases, is the hallway and the anteroom are considered the clean zone, and the dirty zone is considered the patient room. So staff member would go into the anteroom, put on their PPE, go into the patient room. When they were ready to leave, they go to the door by the patient room adjacent to the anteroom, take off all their PPE, go through the door, and the anteroom was a clean room. We had to change people's view and focus on that. We couldn't have a clean room and a dirty room. We really need to start using methodology that we use when we talk about decontamination or other industrial hygiene process of having a clean zone, a cold zone, a warm zone, and a hot zone. So fortunately, it was terminology that people were able to grasp really quickly and start applying, but the hallway really became the cold zone. The ante-room where patients or where staff members are going in and out of was the warm zone, and the patient room was the hot zone. We also needed to determine the roles of the individuals wearing the PPE. And I'll go through these and I'll talk about how it actually compares with some of the CDC and Public Health Agency of Canada roles. But we developed this before those guidelines and those standards came out, but we said on a trained observer. So this was an individual that would never go into the hot zone, would never go into the warm zone, would always be in the cold zone, but they were an expert on how to put PPE on and how to take it off, how to don it and how to doff it. Primarily, these were infection prevention and control individuals that we trained to be able to do this role. When we get through the steps that you're actually doing for the donning doffing, it's extremely complicated. So the role of this individual was actually to go through a checklist and make sure each one of those steps were hit and to make sure that there were no breaches. So doing that type of observation. Again, being in the cold zone, removed from this environment. The PPE Doffing Assistant was a role of somebody that would be helping assist the healthcare member that actually was in the patient's room take off their PPE when they came out into the warm zone. And so this individual would have to obviously be trained, and they would have a specific set of PPE that they would be wearing, and they would be located in the warm zone, in the doffing area. And then there's the individual actually entering the Ebola area, and they would receive very specific training, and I'll talk about that in a couple slides. How this differs from what we do in Fraser Health and most of the health authorities in BC and what was outlined in PHAC and CDC is we completely separated the trained observer and the doffing assistant role. We didn't want to have anybody that was responsible for going through an extremely detailed checklist and keeping an eye out for breaches and guiding the process, also doing hands-on. CDC and PHAC allow for the trained observer type role and the doffing assistant role to be combined into one. We felt that introduced too much risk, so we did keep those as completely separate roles. And that is consistent across most of the health authorities in BC. And it certainly is consistent. It's the only practice that's being used in the designated facilities where we would receive confirmed or actual cases of Ebola. So now that we kind of had an idea of what the roles were and what we were dealing with, we were looking at some of the different risk levels and the categories of PPE. And again, this lines up very, very similarly with what CDC had. But we looked at low-risk patients having low-risk PPE and high-risk patients having higher-risk PPE. Now, starting with the doffing assistant, what we require for a doffing assistant, now this is an individual that's not going in the patient's room. All they're going to be in is the warm zone, and their role is to actually help, if needed, the healthcare worker that's come out of that hot zone remove their PPE. So they're primarily only going to be touching that individual with their hands. So they've got a double set of gloves, inner and outer gloves. They've got a fluid impermeable, fluid resistant, fluid impermeable now gown. Leg covers, knee-high fluid impermeable leg covers. Mask, and a face shield. So again, this is to protect them as they're touching that individual and help touching the healthcare worker as the healthcare worker is removing and doffing their PPE. For the low-risk patients, so these are the dry patients that might show up in any of our emerges. So these aren't the patients that are wet or the patients that are in our actual high acuity unit, but these are for our emerge departments that would be in the lower risk, dealing with the lower risk patients. They require basic skin coverage over their entire body. So again, a fluid impermeable gown, 2 sets of gloves. They've got a set of rubber boots with knee-high leg coverings there. They've got an N95 or a procedure mask. They've got a face shield, and then they've got a full fluid impermeable head cover. So all exposed skin is fully covered. Now when we get to the high-risk patients, dealing with the high-risk patients, we ramp up the PPE fairly substantially. Because we're dealing with wet patients, we want to really have robust PPE that's capable of dealing with that. So in this case, we've got Tychem QC or SL coveralls, which are totally fluid impermeable and chemical resistant. So there's lots of benefits to these. Again, a double set of gloves, set of Tychem tape, which actually forms a seal around the gloves and the coveralls, rubber boots, and a VersaFlow, 3M VersaFlow PAPR. Now, if you remember back to a couple of slides ago, I never mentioned that this is an airborne spread illness. So you may be wondering why we're actually using a PAPR, and there's a couple of reasons for that. It isn't an airborne spread illness, so it is a contact spread illness. But, sorry. PAPR is powered air purifying respirator. So we do use the powered air purifying respirator because if you've ever worn these coveralls, they get very warm. and we would have staff in these for an extended period of time, and we needed a way to make them comfortable. If we put them in a procedure mask with a head cover, it becomes incredibly hot and difficult to wear, and we needed to maximize the time that staff were able to wear these. And with a PAPR, it also gives you really good visual acuity, keeps you cooler, and you've got a really good range of vision for what you're doing when you're doing your clinical procedures. So even though we don't require that level of protection, it gives you those benefits, and it gives you really good coverage on your body from any splashes. Now, that's the figure on the left, which is the Ebola PPE. The figure on the right is something that we use in our emergency departments, and we've used in our emergency departments for the last decade when we're dealing with chemically contaminated patients. So this isn't new for us. I mean, it was new for a lot of our staff that work in the areas that are dealing with Ebola, and it was new for some of the health authorities that hadn't really implemented this. But in terms of the PPE used in decontamination, so this is if a patient comes into our emergency departments and they've been splashed with an industrial chemical, or they've attempted to ingest a chemical and they've poured it on themselves, or they've been in a meth lab and we need to decontaminate them before we bring them into the facility. So very, very similar PPE that we use in that situation. The only real difference is the sets of gloves that we use are more robust because we need something that can withstand any wide range of chemicals. And the type of powered air purifying respirator we use in the emerge is also different because we need something that, again, can withstand a wide range of potential chemicals that are maybe unknown to us. Whereas the type of PAPR that we use for Ebola only has a particulate filter because that's all that's needed for them. So it was a concept that we were able to fairly easily sell within most of the health authority because it was something that we had been utilizing for a number of years in our emergency departments. So in terms of looking at this available PPE, this is just a small sampling of what we were looking at. So again, we were getting asked by our leadership, we were getting asked by our logistics folks, let us know what we need to order because if we don't order it now, we're not going to get it. Well, we can't order something until we actually assess it, and we don't actually put any requirements or recommendations in until we've actually got a physical sample of it. So we need to actually get physical samples because what's down on paper and what you actually see are often very, very different. Sizing is different, the material composition is different, the specs are often very different than what you actually see when you see a physical sample. So we were continually evaluating every available product. Our logistics folks, our supply chain folks would find something that's available. They'd say there's 1,000 of these, should we order them? We'd rapidly get a sample and assess it, evaluate it, and make a recommendation. So our turnaround time had to be extremely quick. Then we started to procure PPE. So we started to fill pretty much every nook and cranny we could with PPE with the anticipation of how many patients we might have and how much PPE we would need. And I'll show an overview of that towards the end of this presentation, which will be, it's a fairly large quantity we're dealing with. So procurement was certainly a challenge. So in addition to identifying the roles of the PPE, the types of the PPE, starting to get that PPE, we need to develop procedures and processes. We need to develop education and training for frontline staff, education and training for our trainers. We need to develop tracking processes. We've got very robust tracking and reporting process, but we need to make it specific to Ebola so that we could report on what our current status was. We developed team sites, SharePoint sites. We developed local expert training with lesson plans for our local experts, and we needed to have a coordinated way to get the education training out there. So we were doing all of that in a very rapid time frame. For our lower risk areas, the education training required for them was awareness level, then some initial hands-on, getting familiar with the equipment, putting it on, taking it off, and ongoing practice. In order to accomplish this, we have almost 1,400 emergency nurses across Fraser Health, across 12 hospitals. We need to engage the clinical nurse educators and the infection prevention control experts at each of those sites, train them up to be able to deliver it. Because our team wasn't capable, there's 2-3 of us, we've got 4 hygienists in total, we weren't capable of going out there and delivering all this stuff, certainly not from a sustainment perspective. So the utilization of local experts is a model that we've been using for many years, so it was quite easy for us to kind of wrap ourselves around utilization of that model. But we need to get those 70 local experts trained, we need to get them the materials, and we need to get it done quickly. For our higher risk department, our designated department, which was at Surrey Memorial Hospital, again, we needed staff to go through awareness, initial hands-on. Then they needed to go through 10 one-hour practice sessions before they could even be considered to be allowed to go into the room. And then from there was ongoing education training drills that they were required to do every month, in addition to simulations, which I'll talk about again in a little bit. In order to deliver that and sustain that in our high acuity unit, we needed to train 12 local experts. So these local experts were trained at a higher level than the 70 that were trained for low risk. And we identified a particular unit where we would be doing this at Surrey Memorial Hospital. In terms of our emergency departments, this was one of the areas we focused on. I'll just touch on this quickly, but a lot of signage went up. So I don't want it to seem that all we did was talk about PPE, because there was a lot of stuff from an engineering control perspective, a lot of stuff that we did from a procedure perspective that was also integrated into this. Being that I've got 45 minutes to kind of talk about this, I can't really get into that, but there was a ton of other supporting processes that happened. Within our emergency departments, one of the things we've done over the last decade is, as we've done new builds and done significant renovations in our emergency departments, is build in interior decontamination rooms. So again, for any patients that come in that are chemically contaminated, they may self-present if they don't come in through ambulance. We've got interior, in most of our hospitals now, we've got these decontamination rooms where we can actually decontaminate the patient inside the hospital. It's a negative pressure environment. It's meant to be hosed down and washed down really well, because we never know what we're going to potentially be dealing with. And there's also clinical hookups there to provide care. So in most of our emergency departments, we identified those as the rooms that if an Ebola patient came, that's where we would have them, because these were dedicated, they were ready to go, and they had the clinical hookups that were needed to provide care. The other area was our Biocontainment Treatment Center. So originally, we called this our high acuity unit. It's still located in our high acuity unit, but it is the Provincial Biocontainment Treatment Center, our high acuity unit for dealing with Ebola patients. We were very fortunate, and one of the reasons we were chosen in Fraser is the fact that we had a brand new tower that was built that had just opened up at Surrey Memorial Hospital. So there was just a huge expansion, huge emergency department expansion, huge tower expansion at Surrey Memorial. That's been going on for about 15 years, but it was just launched about a year and a half ago. So our Biocontainment Treatment Center was part of our high acuity unit. So this floor plan just shows our high acuity unit, which is part of our intensive care unit. And we took a quad area out of that, a pod that wasn't being actually utilized at that point in time. Again, we're very fortunate, because in most hospitals, pretty much every space, every bed is being utilized, but because we were just going through the implementation of this area, this was an area that was still available, and it wasn't being used for clinical care. So again, this is just a little bit of a closer picture of the unit. We looked at 3 areas, and we've set 3 areas to deal with Ebola patients. The bottom right corner is our primary location, because it's the largest room and has the best accessibility. We also identified 2 other rooms where we would deal with Ebola patients if needed. There were a couple areas with PPE storage, so we tried to maximize the amount of PPE storage on the unit. There's also adjacent PPE storage on adjacent units. There's PPE storage in our basement, and then we've got PPE storage in our larger warehouse. The MDR stands for medical device reprocessing, and this we want to have on unit as well. So normally in healthcare, whenever we use a lot of our reusable clinical instruments, that goes down to the lower level of the hospital, which it gets reprocessed so it can be disinfected and sterilized and reused. In our case of Ebola, we don't reuse any medical equipment, but what we do reuse is some of our PPE. So for example, we're not going to throw away the PAPR, the powered air purifying respirator blower unit, every time that it's being used, because it's about $1,000 a piece, and there's absolutely no need for it to be thrown away. We want to make sure it could be disinfected. A lot of the PPE does get thrown away, but there's certain elements that can't be thrown away. So we needed to have the ability to do that disinfection on unit, so we set up a room to do that. Now this was a brand new unit when we moved in. Had just, like I said, just been opened up. But we started to do some fairly significant modifications. So this area here wasn't here when the area opened up, but we need to expand one of the rooms to have a larger anteroom to be able to get not only staff in and out, but to be able to get larger equipment in and out potentially. So we had to extend that into the hallway, and we developed a negative pressure area off of there that we would use it as an anteroom. This entire wall has come out. So if we go back a couple slides, you can see this is our primarily Ebola room where we're going to have an Ebola patient, and the room next to it is empty. What we want to do is convert that into an anteroom. So we had a really large anteroom to be able to deal with. But in order to do that, we need to knock down a wall. So again, this was a brand new build. It hadn't actually been used for patients, and we were already looking at knocking down walls and installing doors and modifying it. So a lot of changes to the physical layout of the unit to actually make it usable. There's a lot of changes that are still ongoing. But again, we were fortunate because we had that unit. It was state-of-the-art in terms of equipment that was available there, wasn't in use, and we had the ability to go in there, do training, start knocking things down and moving things around. The next few slides I'm going to go through fairly quickly. I'm not really trying to get to the detail component of it, but what I want to do is really stress the staffing and the resourcing levels really required to deal with an Ebola patient. So this is one of the models that we're using. And in the upper right corner, this represents the Ebola patient's room. Adjacent to that is the anteroom, where you would go into the Ebola patient's room. This would be the anteroom where you would go out, so that area that we knocked down the wall and put a door in. And this would be the hallway, open hallway, the observation station. We always have 2 nurses in the room at any point in time. And there's a couple reasons for that, but one of the main reasons is it takes a long time to put the PPE on properly. It takes a long time to take it off. So we're looking at least 20 minutes to don the PPE and 30 to 40 minutes to take it off. So if we only had 1 nurse in there and that nurse needed to get out, it would take a significant amount of time for somebody to get in there and replace them. So we always want to have 2 nurses providing that care. Now this could be in addition to physicians that might need to be in the room, respiratory therapists that might need to go into the room, or medical imaging staff that might need to go into the room. But there's always 2 nurses in the room. So what I'm going to highlight here is we've got 2 nurses in the room. We're going to be looking at doing a shift change or getting them out of the room. So the infection prevention control practitioner would get 1 nurse donned up to be the doffing assistant. And that person would go into the anteroom. Once they do that, which takes 10 to 15 minutes, then they're going to don 2 more nurses to go into the room and replace the nurses that are already in the room. So that's 20 minutes apiece to get that PPE on. Then those 2 nurses would go into the room and they could start to replace and relieve the 2 nurses that are in there. But we're only going to be able to get 1 nurse out at a time. So that first nurse goes out, starts doffing. The infection prevention control person is the trained observer doing the observation, leading the instruction. We got another nurse in the room that's helping with the doffing. 30 minutes later, that nurse can leave, and nurse number 2 goes in and starts doffing. Again, another 30 minutes before that nurse can go out. Then the doffing assistant needs to doff their equipment, and that's going to be guided by the infection prevention control trained observer. And then they can leave the room, and that's 1 rotation. Now, if you note the time in the bottom corner, that's 2.5 hours just to swap out those 2 nurses. And if you look at the number of nurses that were involved in just getting the 2 nurse in the room model, there's 5 nurses involved. There was a carrier involved. There was a patient care coordinator, which I really didn't talk about, but they're always observing what's happening in the room in case something is needed. And there's an infection prevention control person that's doing the trained observer role, the donning doffing. And then there's also physicians, respiratory therapists, and medical imaging. Our goal was to not have anybody in the room for more than 4 hours. So that would be 6 switches throughout the day. So just in the room itself, not factoring in the doffing assistants or any of those other roles, it's 6 times 4, or it's 6 times 2. So we've got 12 nurses that would have to rotate through a 24-hour period of just being inside the room. And then you've got all these supporting roles. So once you start adding that up, just caring for 1, and that's 1 patient. That's not talking about 2 patients or 3 patients. That's just 1 patient. Our numbers start to get really large. So we knew this was going to be an issue at the onset, and we wanted to develop a core team in our high acuity unit that really focused and was specialized in dealing with these individuals. We knew from the onset we want to keep this a sustainable model. We didn't want to just respond to Ebola and then 6 months later, once things started clearing up and Ebola was out of the news and we weren't really having to worry about it, that we would just forget about it, and then 3 years later when Ebola crops up again, we're in the same boat. We want to make this a sustainable model. So we knew we need to develop a core team that could have ongoing drills and practices. One of the things that was interesting in how we got this core team is very different than how we normally train staff. In our emergency departments, for example, all of our staff, all of our nurses are trained because any one of them may come in contact with a patient. And that's typically the model we use for a lot of our education training because of the rotations involved. For the core team, we want to identify people that really wanted to be involved. And so an expression of interest went out. We worked with the unions to get this expression of interest. And anyone that was interested applied, and they would become part of the core team. Now, if you look at the numbers of nurses, 55, that's a large number. And we've got a lot of nurses in our intensive care and high acuity units at Surrey, but not enough to fully cover this. So we had to start looking at some of our other facilities in Fraser Health and bringing in those specialists. We also look to other health authorities, VGH, St. Paul's, Children's and Women's, in terms of bringing in some of their staff. So they're part of the core team as well. In addition to the nurses, we've got the patient care coordinators, we've got the respiratory therapists, we've got physicians, we've got the medical device reprocessing folks, we've got lab folks, trained observers. So in total, we're looking at about 140 people just to care for the groups. And we're only talking about maybe 2 to 3 patients we would have to care for. So a large contingent of staff to be able to deal with that. Part of what they do, so I talked about the fact they need to go through initial training, they need to do their hands-on training, they need to go through 10 practice sessions before they're even able to go into the room. In addition to that, they have to go through monthly practice sessions as well as simulations. So it's all fine and dandy if people know how to put the PPE on and can wear the PPE, but they need to be able to wear it for extended periods of time. And they actually need to be able to carry out their clinical work, which is fairly important for what they do. So we do simulations on a regular basis where we'll run through either half-day or full-day simulations where the physicians, the nurses will actually do clinical procedures, fully dressed up, fully following all the protocol, but practicing to make sure that they're fully confident and comfortable in wearing the PPE and being able to carry out their processes. So in this case, the physician's going to be doing a sterile procedure, so he needs to put on a sterile gown because the coveralls that we're using aren't sterile. He needs to put on a sterile gown, and he's put on a set of sterile gloves as well. So now he's triple gloved. So he needs to be able to make sure that he can actually do those clinical practices wearing 3 sets of gloves. Losing a lot of tactile sensitivity when you're putting on 3 gloves, so they need to practice to make sure it was actually doable for them. And these are just some other pictures of some of the things, some of the simulations. So certainly a lot of work from the education training component and a lot of work from the simulations. I mean, we're talking about 140 staff. We're trying to rotate a lot of them through these simulations and having as many available to participate as possible in these various simulations. So there is a lot of work on coordinating that and carrying it through. In terms of the logistics, I do want to put some perspective on that as well. So now from the human resourcing perspective, you can see kind of the scope of how many staff are involved. But from a PPE perspective, that's also a very large amount. So on any given patient, if we're dealing with one patient, we would anticipate 25 sets of PPE per day. And we'd be looking at up to about 20 days where we might need this PPE for an individual patient. So about 500 sets of PPE. So when you expand that out, you're looking at a lot of sets of PPE. That's just one patient. In terms of how we're going to get rid of the PPE, well, we've got disposal drums that we use for getting rid of that. And we've run through these numerous times in simulations to see how many of these drums would be required to actually hold this the PPE waste. So within the Ebola patient room, we're looking at anywhere between 4 to 6 drums. Within the doffing area, another 4 to 6 drums. In the medical device reprocessing area, 4. In the lab, 4. So about 16 to 20 drums per day are being used, up to 400 drums over the course of 20 days with one patient. So we're not talking small drums, we're talking large barrels here. And if you expand that out, that's a lot of drums that need to be used. There wasn't this many drums available in Canada. In BC, we had about 16 of these drums in the warehouse when we started this off. So we need to procure a huge number of these drums because we can't wait till put an order in when it happens, because if we've got a patient there, we need to be able to get rid of the waste. If we're going through 20 of these drums a day, we need to have that readily available and on hand. And when you expand that out again, that's one patient that we're dealing with, so you can imagine the amount of waste that's happening that needs to be managed. So when I talk about the PPE side of things and all the PPE we're using, large volumes of PPE, there's the whole waste management stream that we had to map out to see who's going to take that waste, how's it going to get off the unit, where is it going to go, where is it going to be held, how is it going to be disposed of, because it can't just go into regular waste stream. It all needs to be accounted for, every single drum, every piece of PPE equipment, because there's bioterrorism concerns when you start dealing with Ebola virus. So it needs to be fully controlled, it needs to go through all security processes, and needs to be fully locked down. So while I've talked about some of the PPE and the education training, it's really just a very, very small component of the overall work that's been done on this. And this is just a very small component of just some of the other things. And I'm not going to go through this, but just to highlight the fact there's from housekeeping to dealing with spills to daily cleans, there's a huge amount of processes and procedures that need to be mapped out, needs to be developed really quickly. and evidence-based and very solid. They've been refined. We're continually refining them. They are provincially standardized, all of these things. So that was one of the great things that came out of this. When you compare it back to SARS, or severe acute respiratory syndrome, which was an issue back in 2003, near when I started in healthcare. And every health authority was doing something different. Every facility was doing something different. Every department in every facility was doing something different. They were kind of going down their own streams. So this is a much, much more coordinated approach, being coordinated through the ministry, with all the health authorities at the table, all having those conversations, working together. We've been able to really focus and really get a standardized set of guidelines and procedures out of this. And again, it is evolving. So before we started Ebola, it was very minimal stuff. During the whole last year, there's been a lot. It has evolved over the last year. Where we're at right now is we're looking at how to sustain this. Going forward, there's some stuff in the works which we're really excited about to actually make a provincial biocontainment treatment center as a permanent fixture, a permanent sustainable fixture. There's some conversations happening, and we're hoping to get some decisions on that in the very, very near future, which is going to be extremely exciting because we'll be able to sustain this. So the next time we have Ebola, and it might be Ebola, I mean, there's work on vaccines that might prevent some Ebola outbreaks. It's not going to prevent them all, but if it's not Ebola, it's going to be something else. And the fact that we've gone through SARS, we went through H1N1, we went through Ebola, we need to learn our lesson and be prepared for when this comes so that staff are ready to go, it's sustained. When this comes in the door, we can manage it and we can deal with it and mitigate it extremely quickly and well. So that wraps up my talk. Again, from an acknowledgement perspective, we've had so many people across Fraser Health that have worked on this and across the province, many, many more than I can mention, but certainly I do want to mention a few. Rita Chikante, who's our program lead for exposure prevention, and Samira Kermanchi, who has left Fraser Health but was our infection prevention control education consultant. We were the three that were kind of locked in that room that you saw that stuff piling up on for a couple months, so we got to know each other very well. I've known Rita for forever, but Samira was new to our group, so Dave Keane, who's our executive director, and our medical health officer, Dr. Elizabeth Brodkin. All instrumental, so much work that was done on this. And the team, one of the things with the core team, it was very interesting because all these people were really interested in being part of that. So a lot of times when you do health and safety training to groups that don't really want to be there, they know they have to do it, but they're really not that engaged. These are folks that are super engaged. The physicians right across the board, we've never had that much interest and eagerness from people that would really want to be there and really want to, they hung on our every word when we talked about hygiene. So it was really a great experience, and we're looking forward to where we can go from here. So thank you.
Okay, thanks, Quinn. I'm going to do something I've never done before, which is start with an online question. Alec Lee asks, how did your PPE recommendations compare with those from the CDC?
So our PPE recommendations were very similar to the CDC. One of the things we had to do is we did have to develop some in-province procedures. CDC, for example, says you need to wear wipeable shoes. Well, we really want to wear boots because we felt that was a more robust level of protection. That changes the order in how you put things on and how you take things off. So we couldn't just replace what the CDC said with, for example, with wipeable shoes and just plug boots in there. It really changed a lot of the processes. So a lot of our stuff is very consistent with CDC. CDC doesn't recommend or specify specific brands of PPE. So we had to take those recommendations and apply it to specific brands and make sure those specific brands were able to meet those requirements, but very close to what the CDC has recommended.
Hi, I just have a question with how you got to decide on what PPEs to use. So I noticed that you said that the PPEs that you use for Ebola patients were kind of similar with workers who were exposed to industrial chemicals. And I was just wondering, who decided on making or modeling PPEs that was very similar to those?
Great question. At the onset, when we were asked for our input, we had recommended that we use decontamination PPE because eMERGE staff were already familiar with it. It was already part of our system. Some of the concerns that came from across the province were that staff had never seen this. They wouldn't be able to put it on and take it off properly. So we kind of went through a bit of an evolution process in terms of what we were using. We were able to convince folks, though, that the PPE that we were already using made a lot of sense for exactly the same applications. And when you looked at what the CDC was recommending, and they talked about if you're wearing full coveralls that had impermeable seams, really the gowns and coveralls that we were using already had that. So we just adopted really what we had and implemented that.
Hi, thank you for the talk. Was there any preparation undertaken this summer for MERS virus? I know it didn't get a whole lot of attention in North America, but sort of in other parts of the world, it was sort of a big deal.
Yes, so there was. It's something that we've been looking at for, well, since it's emerged a couple of years ago and really been looking at it. So the preparation is there. The nice thing about a lot of this preparation is it kind of blends into some of those other preparations, so it gives us that ability to be a bit more fluid in what we're responding to. But it certainly has been in the works for a number of years.
Hi, thank you. How scalable is this as a solution for treating multiple patients? It seems like this would work if you were doing, say, 5, maybe even 10 patients simultaneously, but if you had a larger scale outbreak, would you expect to scale this up to do, say, 50 patients at a time? Or is there some point at which you would say, no, now we need a fundamentally different system, we're going to be moving into a different facility, or it would be some sort of national or military level response?
That's a great question. So we did look at scalability. I mean, as you can see from kind of the PPE and the process that we have now, we couldn't scale up to more than a handful of individuals. So we did create the network, Public Health Agency of Canada, and work with them that if we had a situation where we had 15 people show up in BC, and it would be extremely rare that we would see that, but if they did, then we had the ability to actually contact other health agencies across Canada, have a transfer of those patients, as well as Nebraska and Emory in the States, which are large facilities that deal with biocontainment and rare pathogens. So those contacts were made, and that kind of network was developed that if patients had to be transferred. BC Ambulance has ways with their isopod of actually flying patients in from the north, so we have ways of actually flying patients across areas into other areas. But certainly from our capacity perspective, we wouldn't be able to deal with more than a handful. The nice thing about the way everybody's being tracked at the borders, though, is we would have a good heads up if we start to see an influx of individuals. So everybody that's coming in from the affected regions is being followed up for the entire incubation period. So if we did start to see people developing, it shouldn't hit us at an immediate time. We should start to see that and be prepared for that type of situation.
I'd like to know if your core group received any incentives just to be part of that team, and also were the boots reusable, or did you just discard them?
Good questions. So the boots were reusable, they were reprocessed, and the core team didn't get any additional incentive. It was just part of an expression of interest in whether they were interested in doing it. Particularly because this is a weird and wonderful thing, when you kind of see that in healthcare, people tend to gravitate towards some weird and wonderful things. One of the things that we heard right from the onset was when they saw the PPE, they saw the work that was being done, they felt that wasn't even an issue for them. They knew they were going to be fully protected, so they were extremely confident in that. And then that gave them the ability to say, I'm interested in this. This is something weird. I may never see this in my career, and I want to be part of this. And certainly from the physician group, we saw the exact same thing where the physicians thought this is a good opportunity to see something that I'm in it, have an opportunity to see, and they want to be part of it. But the key was really making sure that they felt fully protected and able to respond without having any potential exposures.
I'm going to ask a question before I let you ask a question. So you guys are holed up in your room in Fraser Health. Are there equivalent teams holed up in their rooms in the other health authorities and in the other health authorities across Canada? Like, is this wheel being reinvented over and over, or are you all working together to come up with the same thing?
Variations. So we were kind of a subgroup holed up within Fraser Health. We had a larger emergency operations center group that was kind of seconded and working together, and we were kind of a subgroup of that. Within the other health authorities, they had similar emergency operations centers set up. There probably wasn't the extent of focus from the other health authorities from a hygiene and infection control perspective of people being very focused on this, but they were certainly engaged throughout the process. So I don't think there was much duplication in that work, and each health authority had to deal with it a little bit differently in terms of the logistics and how they're going to work through it. So even though we had guidelines and processes that were very similar that we could apply, you had to get down to that local level to actually implement those, and that was a big time commitment for all the health authorities.
You mentioned that in the future that you would be able to hopefully learn from the lessons from other flus or other very pathogenic viruses or bacteria and whatnot. But do you think this sort of method or guidelines for PPEs will be transferable for other contact diseases or similar pathogenicity with such as Ebola?
Absolutely, and that's what we're looking at carrying forward. So we're looking at taking what we have now and not just looking at other rare pathogens, but looking at some of the similarities we have between decontamination and rare pathogens. So our staff in our emergency department might need duplicate training on two sets of PPE and two sets of procedures that are very similar but slightly different, and we're looking at ways to make that as a more efficient education training. But from a PPE perspective, certainly, that's what we're looking at from a rare pathogen perspective and making the PPE that we're using for this apply across any type of rare pathogen that we might see.
Okay, we have a couple of online questions. The first is, how did you test the efficiency of your PPE to know that it worked well or was adequate for protection from Ebola?
So part of it came from what the CDC guidelines and the recommendations from there, and then part of it was our knowledge of the PPE itself. So for the coveralls, for example, those are coveralls that are used in hazmat situations, the stuff that we use it's totally fluid impermeable. You're talking surged and bound seams, so we knew that liquid isn't going to get through that, and there's a multitude of tests that have been done to test fluid impermeability of that type of equipment. So we looked at a lot of those specifications that already existed and assessed those in order to determine whether PPE was applicable. One of the challenges when we came to the head covers is CDC, Public Health Agency of Canada, was requiring fluid impermeable head covers. So this is for the lower risk that we're talking about. So this isn't the high risk, but the low risk had fluid impermeable head covers. Nobody made fluid impermeable head covers. They didn't exist. There is fluid resistant, but not fluid impermeable. So now there's a company actually based in Nova Scotia that's making fluid impermeable ones. We assessed dozens, even the ones that were originally coming out as fluid impermeable, they weren't fluid impermeable. They were listing them as that, but they weren't meeting the requirements. They didn't have the ASTM standards testing. They didn't have any of that testing. So yeah, we did assess it from the specs, and we did assess the physical samples as well.
Okay, and negative air system maintenance. How did you manage the filter element changes?
So that was an item that we managed through our facilities maintenance, and it wasn't any different than how we manage our filter changes for regular infectious agents, because Ebola is an airborne spread. So we weren't concerned about that, but the contact spread and the way filters are changed for our facilities maintenance and operations staff, they've already got a set of procedures, and it's adequate to protect them from this type of disease.
Okay, if there's no further questions, I'm first going to say that there is quite a lot of chocolate cake left over from the B-Corn AGM last night, and it's upstairs in the lunchroom, so any students who are feeling ravenous and need some chocolate cake, or any faculty, please help yourselves. And then